From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Author Interviews podcast. Today, I'm so pleased to be joined by Dr. Stella Dantas, who is an obstetrician gynecologist and is serving as the 75th president of the American College of Obstetricians and Gynecologists. Welcome, Dr. Dantas.
Thank you, Dr. Brubaker. Thanks for having me.
We were so pleased to be able to publish your contribution of you and Dr. Greaves on advanced birth centers and the effect on maternity care. You and Dr. Greaves made the point that access to quality maternal health care requires all stakeholders to come together to create evidence-based, safe, accessible solutions. So let's talk a little bit about what is going on in Florida. Let's start by giving all of our listeners some context about what birth centers have been for the past decade or so. Tell us about birth centers before this new proposal came through.
So birth centers before this new proposal are what we would think of as accredited birth centers. And these are places where people can give birth, and they are for low-risk singleton term vertex pregnancies, not for high-risk pregnancies, not for cesarean sections, but low-risk singleton term vertex pregnancies for a vaginal birth.
And how does this new proposal in Florida differ from the traditional accredited birth center?
So the Florida law is for an advanced birth center, which is now one that would allow birth centers to have planned cesarean sections, as well as TOLACs, trial of labor after cesarean section, and VBACs, vaginal birth after cesarean section. So they're allowing these surgical procedures to be done in a birth center.
So this inclusion of cesarean section is a major departure from practices of accredited birth centers.
Yes, these are allowing, I would say, higher risk conditions and procedures to be done outside the hospital, which was not the intent of birth centers.
Now, certainly cesarean delivery can be life-saving, and every clinician who's been around a birth can be fully aware that during a delivery, someone who's low risk and in a planned delivery to be low risk can convert to a high risk or critical situation in just a matter of minutes. So this could be very concerning. Cesarean sections are very, very common. You and Dr. Greaves indicated there are approximately 1.2 million performed in 2022, but the surgery is not low risk. Can you talk a little bit about what the risks could be?
Yes, so exactly it. Cesarean sections are very common, but they are not low risk. And I think that's where the conflation lies. So cesarean sections, even if it is a planned cesarean section, can turn into a high risk situation at any point. And any delivery can. However, cesarean sections can have, potentially higher risk of a hemorrhage, risk of hysterectomy, risk of renal failure, risk of sepsis, and there's also risks to the fetus. So it's a higher risk situation, and an infant can require more support that a birth center would have the personnel to do. So there are a number of things that would not necessarily be available in an advanced birth center if a planned cesarean section turned into a high risk situation.
You raised the issue of vaginal birth after cesarean section, and it's understandable that someone would want to follow up a cesarean section with a trial of labor and have a vaginal delivery. The advanced birth center may not be the ideal place for that, though, given the risk of uterine rupture. Could you talk about that a little bit?
Yes. So a trial of labor after cesarean section, there is risk of uterine rupture, and every patient is counseled about that. And a uterine rupture is something that you have to address immediately. And you need immediate availability to a surgical suite. You need availability to a blood bank and extra hands and personnel to save the life of a patient and to save the life of the fetus. So you need to be able to respond within minutes. And if you are doing a trial of labor outside the hospital, you do not have the transport capacity that gets you into a hospital that quickly to be able to do what's necessary to save the patient and the fetus.
You've made the point that there's importance on the safe care of the newborn here as well, and the newborns who are delivered by cesarean section have a higher risk of transient tachypnea as well.
Yes, and that's why, availability of trained staff, potentially NICU staff, to be able to address those concerns need to be available. And those would not be potentially available in an advanced birth center.
As I understand it, one of the drivers for this was to improve obstetric access. It's my understanding that only about 10% of rural hospitals in Florida are currently providing obstetric services. Why is the obstetric access so low in rural Florida?
Well, there are a number of reasons that we have so many maternity care deserts in Florida. One is reimbursement levels, right? We know that Medicaid is covering a large number of deliveries and they're not reimbursing at what the cost of care is. So these labor and delivery units cannot maintain staying open. It's not financially feasible for them to. So then they end up closing. There's also personnel issues. You're not able to get enough staff to stay in these areas and work. And with OBGYNs right now, with the legislative interference that we're seeing in Florida, we are seeing physicians leaving the area. So you have a smaller number of physicians to work in these labor and delivery units, and you cannot staff them safely. And so they're having to close. So there are a number of pressures in these areas that are not making it feasible for these birth centers and labor and delivery units to stay open.
And I think this is exacerbated somewhat by Florida not being a state that has expanded their Medicaid coverage as well.
Yes, that's exactly getting to the reimbursement issues with the large number of deliveries being covered by Medicaid and then the reimbursement also not being where it needs to be.
It might be tempting to think about having the advanced birth centers geographically close to existing hospitals. It may provide some ideas of safety for rapid transport or additional resources, but that somewhat defeats the purpose of expanding access, and it may actually siphon off much needed obstetric volume so that that hospital can continue its operations. Any thoughts on that?
Yes, the intent of expanding access and the intent of these advanced birth centers is just that, right? We want to help provide access to our pregnant patients. And there is a requirement to be able to transport patients out of them. There is no proximity requirement. However, as you stated, in terms of safety, it would be better to be able to be closer to a hospital, to be able to provide care in a higher risk situation because time is life-saving, right? However, where we're seeing these maternity care deserts are not near a hospital. So the intent, so that we're able to provide care in these rural places that don't have access may not be feasible. The other thing is if you're putting these birth centers in places where we're already struggling to keep personnel, you may be siphoning off personnel to staff these birth centers from your hospitals that can take care of all the situations. And so you're further compromising care there in terms of siphoning off staff or even physicians, and then also siphoning off deliveries, right? We need deliveries to be able to provide care. You want to have a certain number of deliveries at your hospital to make it, again, financially feasible if we're not able to keep those units open, but to also make sure that we are providing safe care.
You've really beautifully outlined the significant challenges that add to the overall picture of a worsening maternal morbidity and mortality problem here in the United States. Dr. Dantas, thank you so much for the work that you're doing with the American College of Obstetricians and Gynecologists. And thank you for joining us today. And thank you for you and Dr. Greaves contributing this important viewpoint.
Thank you so much, Dr. Brubaker, for having me and for the work you do.
Well, it's been a pleasure speaking with you today. I'm Dr. Linda Brubaker, Deputy Editor at JAMA, and I've been speaking with Dr. Dantas, the 75th President of the American College of Obstetricians and Gynecologists. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, Please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.